That is correct.
Okay, go ahead.
And the way I have you projected, I can't see the chat box right now, but I will address chats and feel free. Is that got it thing showing to everybody right now? Okay.
Yes, it is showing.
I think I'm going to unproject. Okay. Sorry, technical difficulties. Share screen.
Shannon, this is Sandy. It's kind of hard sometimes to watch the chats while you're presenting. Do you want me to watch them for you and then alert you when there's a question?
Sure, that's great. Yep. And I am taking a few breaks to answer questions as well throughout the presentation because we have quite a bit together to cover, and now I can't see anybody. So we're just going to get going. This is again, like Jeannie said, this is a two-part presentation on pharmacogenetics. The talk today is kind of a 1,000-foot overview. In 2 weeks, I'm going to be going more in depth into the actual clinical application and cases. So if you can bear with me on these first 20 slides and not fall asleep, I think we'll be doing good. So the objectives today are to review the fundamentals of pharmacogenetic testing and common enzyme variants for certain enzymes that metabolize medications. I'd like you to learn evidence-based resources and select appropriate patients for pharmacogenetic testing in primary care. We're going to then describe the utility of and challenges to actually implementing this testing into practice, which is something that I hope that you can all at least take away. So we're in the era of precision medicine. Pharmacogenetics is a subset of precision medicine. What we're looking for with this is we're trying to tailor medication therapy to meet individuals based on using their genetic information. So pharmacogenetics is a DNA sample that, as I'll go along, tests for specific what we call single nucleotide polymorphisms or SNPs in diplotypes or haplotypes of patients, enzymes that metabolize medications. When you look at terminology, which could be a whole lecture, genomics is the patient's entire sequencing, and genetics are single variants. So depending on, I use those interchangeably, there is a difference. What we're looking at is we're trying to reduce adverse effects of medications, select medications that may be more effective. You have to take in patient-specific factors with this, which we will go through as well as concurrent medications. So as we know in practice of primary care, one medication does not fit all. It's estimated that, and I would think estimates are even higher, that only 38% of patients respond to a particular class of antidepressants. Other medications have implications with low rates of effectiveness or tolerability issues. As we're going through the more precision-based medicine, we're seeing more targeted gene therapies and cancer treatment, which is really improving effectiveness and tolerability. And again, this testing is implicated for certain conditions and certain medications. So if you look at this kind of illustration here, we can give, so let's say we have a patient with a history of depression who we're going to prescribe fluoxetine to an antidepressant. We can give the same medication, the same dose to two patients of similar age and weight, and there can be 1,000-fold differences in their serum concentrations or blood levels. So what we're going for in obviously an ideal medication, the medication would not be toxic and it would be beneficial. That's only a subset of patients, as we know. What we want to avoid are adverse effects and no benefit, right? That's not a good medicine to stay on. What we usually do with that is we change it. We have patients who get side effects to medicines, but they are beneficial. So how do we manage that? What we're doing here is evaluating if enzyme variants or SNPs can hopefully get us more towards here, or maybe here at lower doses. There are certain factors that we look at. So when we show you a panel of pharmacogenetic tests, we look at a class of enzymes that I'll discuss with you, a family of enzymes that can be upregulated, so increased enzyme activity, downregulated, so decreased enzyme activity. There can be certain SNPs that are non-functional deletions, or you can have gene duplications, and all of that plays in. Ethnogenetics is something that factors in. So your ethnic background, there are different prevalences of genetic variants of these metabolic enzymes. We also look at certain receptor sites. So for ADHD medications, we actually look at the alpha-2 receptors. In this testing, we look at serotonin receptors. COMT is O-methyltransferase for catecholamines. And then we actually look at opioid receptors and COMT for pain and psychiatric medications. Another big subset of testing that sometimes is actually required are the HLA hypersensitivity reactions to certain anti-epileptics, such as carbamazepine and phenytoin, which I get into a lot more in detail next time. So when we look at a genotype, which is your two haplotypes, basically, we need to convert that to a phenotype, what your body expresses. That's kind of just basic genetics. Enzymes are categorized based on their kind of function, if you will, their activity scores. So one patient could be an ultra rapid metabolizer versus one could be a poor metabolizer. So when you get your reports, you won't have to memorize these diplotypes that I'm going to show you. It will list that what the patient's expressed phenotype is. This can also change depending on if we want to get even more into the weeds of whether the parent compound is active or it's a prodrug. We have a lot of prodrugs, including clopidogrel, tramadol, codeine. So that actually means that it would be the opposite of what you'd think. If you have reduced enzyme function, you'd have higher levels of the parent compound with reduced effectiveness. And then there's some substrates that I will get into a little bit more in detail next time that are like transporters that transport medications out of the gut to the liver, out into the liver for uptake and elimination. This SLCO1B1 is actually, when you have variants in that, you have a higher risk of statin-induced myopathies. And here's just an example of certain substrates or receptor sites that we look at in pharmacogenetics. This is the mu receptor that we look at. If there's variations in that, you can have various response to certain pain medications. Serotonin receptors, this is the alpha-2 receptor for ADHD meds such as clonidine and guanfacine. MTHFR is methyl tetrahydrofolate reductase. This could be its own presentation, where patients don't methylate certain B vitamins and which can have pretty big consequences in the fields of anxiety, depression, sometimes pain and other blood disorders. That's included in most testing. And then another serotonin receptor. There are several receptors and transporters. This is just kind of a snapshot of some of the most common ones. And then, like I talked about before, we have to keep in mind patients' kidney function, liver function, smoking. So cigarettes and cannabis both are enzyme inducers. They can make the levels of medicines much lower or higher in your body. And then drug-drug gene interactions, which we call phenoconversion in the pharmacy world, where I could be a normal or poor metabolizer and have further reduction in metabolism based on the current medicines I take. And that's just illustrated in this slide. Probably one of the biggest ones we see here is the addition of bupropion, which is a strong CYP2D6 inhibitor. When you look at the collection of expert guidelines, if you are on a strong CYP2D6 inhibitor or inducer, you're phenoconverted to basically a poor metabolizer or an ultra rapid metabolizer. So again, comprehensive understanding of how the drug interactions play onto genetics can really give you further information of why a patient may or may not be responding. So we're going to run through briefly the types of genotype tests and interpretation. This is the major family of isoenzymes that when you hear core URI, look at drug interactions or see drug interactions, this is where it's coming from. They're responsible for the oxidative metabolism of most of the medications that actually undergo liver metabolism. CYP3A4 is the most common. 50% of medicines are metabolized through this. The two that I'm going to focus on are CYP2D6 and CYP2C19 because they're implicated in psychiatric medication management, and pain. So CYP2D6 converts a lot of our pain medications to either active forms or inactive forms, antidepressants, antipsychotics, and then CYP2C19 antidepressants and clopidogrel as well as phenytoin. So if you look at this table, and I'll actually show you where to find these tables. Here we have our diplotype. So this would be the patient's genotype. I'm just going to point these out for a couple of questions that are coming up for you. So a patient wild type, if you're looking at the actual genetics, is a *1, *1. So you get a copy from each maternal, paternal. This would be the normal or expected expression in a diplotype, which would be a normal metabolizer. If you have a variant, so CYP2C19, the *17 variant has increased activity. So a patient who is a *1 wild type and a *17 rapid will have rapid metabolizer phenotypic status. There are some patients who are *17 ultra rapid. So they have a variant from mom, a variant from dad, and they have very high function of that enzyme. When you look at CYP2D6, the ultra rapid metabolizers are gene duplications. So the *1 wild type, they have more than 2 copies. So it would be listed as a *1 times N, *1 *2 times N. This is not a comprehensive list of the alleles at all. This is just kind of some more common ones. So like I said, ethnogenetics plays in because I get a lot of questions like, is this relevant for our patient population? There's some FDA labeling of certain medications that require testing for medicines if you are a different background. So we see CYP2D6 non-functional genes most commonly in Caucasians, and then reduced function in African Americans and Caucasians. CYP2D6 is probably the most variable polymorphic enzyme. There are almost 100 allele polymorphisms that have been documented in the literature. But then we have to think about, okay, well, are you just showing us a bunch of like in vitro interesting things, or does this play out clinically? And when they're documented as such in the guidelines, yes, it does. Here's a table of relationships that's actually in the CPIC guidelines that we're going to review pretty quickly. If you look at the activity scores here, you get your phenotype and your genotype. And I'll show you directly how to get to those guidelines in just a minute. Okay, so we have a clinical example here. We have a CYP2D6 patient. Like I said earlier, codeine is a prodrug, which means it actually doesn't have activity itself. It has to be metabolized into morphine to become active. And that's by CYP2D6. So a CYP2D6 ultra rapid metabolizer would metabolize codeine into morphine. The ultra rapid metabolizers may have increased efficacy and an increased risk of adverse events following codeine administration. So they convert codeine to morphine very quickly, higher levels of morphine in their blood, which also puts them at a higher risk of adverse effects. I have an actual clinical example that shows you why codeine is now contraindicated in breastfeeding, and it's due to pharmacogenetics. CYP2C19, the other most common, again, we see a big wide variability of frequencies of that. Most commonly is the upregulation or ultra rapid. CYP2C19 metabolizes Lexapro and Celexa or S-citalopram and citalopram, and about almost a quarter of patients are increased metabolizers of that we see. There's just the kind of phenotype genotype relationship table from the guidelines for your reference. So I put another prodrug question in here, but clopidogrel, Plavix, what we used for acute coronary syndromes, PCI, to reduce stent thrombosis, is a prodrug. It actually has to be activated by CYP2C19s to the active metabolite. So CYP2C19 poor metabolizers have an increased risk of adverse cardiovascular events and stent thrombosis versus basically normal metabolizers. Why do you think that is? This is kind of a, I'll just answer for you right now. Because they don't convert to the active metabolite, and there are genome-wide association studies showing, and the CPIC guidelines recommend in a patient who is a poor CYP2C19 metabolizer to use ticagrelor instead of clopidogrel due to higher rates of stent thrombosis and mortality. And then on the other hand, if you're an ultra-rapid metabolizer, you may have an increased risk of bleeding. So you're converting clopidogrel much more quickly to the active metabolite, higher serum levels of the active metabolite, have more antiplatelet activity, and increased bleeding risk. If you look at the guidelines, sometimes the FDA labeling, there may only be implications for one end of the spectrum when we're looking at the medications. So you do have to reference those as well. And this goes back to the table of phenotypes and genotypes. I can't see the chat and I can't see anyone's faces. If somebody just wants to pop in and respond, if they saw.
There's
so
nothing in the chat.
What's that?
There's nothing in the chat.
Okay. So the likely CYP2D6 enzyme phenotype for the star 3, star 4 diplotype is ultra rapid, normal, intermediate, or poor. Well, you'd have to go back to the table I just showed you. It's definitely not normal because that would be a star 1 usually. This expression is actually poor metabolizer. And then I did point this one out. The likely CYP2C19 enzyme phenotype for star 17 diplotype is, anyone? Corey?
I think you said the 17 was rapid.
And they have 2 copies of it.
So then I guess ultra rapid.
Yep. Ding, ding, ding. Fun fact, I am an ultra rapid CYP2C19 metabolizer, if anyone wanted to know that. It does exist. Okay, and then this is a interesting, there are guidelines for PPIs. CYP2C19 metabolizes proton pump inhibitors. And there are some studies that have shown that CYP2C19 poor metabolizers have higher H. pylori cure rates than extensive metabolizers. Following omeprazole therapy provide a reason for this observation. So omeprazole is not a prodrug. It's the active, parent compound is active. So if we're having a poor metabolism of omeprazole, what would we expect to see? We would expect to see reduced metabolism, but reduced metabolism would increase the half-life. So that's wrong. Reduced metabolism increases exposure to the PPI, resulting in better acid suppression. That sounds logical.
Ding, ding, ding.
Omeprazole-
agree more.
What's that?
I'm sorry. I just was saying that sounded like the right answer. Sorry.
It is the right answer. You are correct. And then none of the above. No, there actually are studies showing better cure rates in these patients for H. pylori. So we're going to look at the literature right now. What is our gold standard for studies in medicine? It's randomized controlled trials, right? We do not typically see randomized controlled trials with pharmacogenetics. Why? Well, you would need a huge N. These single nucleotide polymorphisms are they are common in the populations, but what we actually typically see are what we call genome-wide association studies, where we take a bigger randomized control trial and then we do a nested case control. So we look at patients within that randomized control trial. So let's just take statin-induced myopathies. Take the patient population who had myopathies associated with statins, do the genetic testing, and determine if any variants in alleles were statistically significantly higher in patients who had statin-induced myopathies. Just to let you know, this is why we no longer use simvastatin 80 milligram doses, because of pharmacogenetics and alterations in patients' ability to clear out simvastatin 80 milligrams was a genome-wide association study. So we can also do, there are randomized controlled trials for pharmacogenetics. They're just pretty rare. What we actually do is a correction for your p-value, because we have a lot of false positives if we keep p at 0.05. And it requires a lot of patients with a lot of different SNPs. So the best gold standard approach, I'll just let you know, is a genome-wide association study, which they do exist as well. They're kind of hard to control. There's a lot of internal bias and sometimes lack of external validity, especially if you don't study them in patients with different genetic backgrounds. You can get things like that, selection bias, and then actual internal errors in how the labs are reporting their actual lab alleles and frequencies that can make the studies less valid. This again could be an entire lecture in itself. Here's just some examples that have been published in the literature. These are actually old trials, are published often. I'm giving you more of the non-psychiatric medication examples right now because we're going to focus on psych meds in our next lecture. But I just want everyone to be aware that there's genotyping for a lot of different classes of medicines. What I'd like to do now is turn to the actual, let me know if my screen isn't sharing anymore. I want to show you where to find the guidelines so you can have more tools in your belt to ensure that you're not just, okay, I have to share screen again, hold on. Not just taking the reports at face value. So CPIC was established in CPIC, PGX. In 2009, it houses, let me actually share my screen again. Okay, can you see that? It's an online database that houses International Clinical Pharmacogenetics Implementation Consortium, houses the most current guidelines, up-to-date evidence for pharmacogenetic implications in medicine. It will give you their levels of evidence, the standardized terminology that I already kind of went through with you as far as like phenotyping. You can go to the guidelines here. Anything listed here has a level A recommendation, and you see your drug gene pairs. I would encourage anyone who's interested on like the utility of this testing to read one of the guidelines just to familiarize yourself with what's included. There are certain gene drug pairs, a lot actually, that don't have a guideline associated, and those are housed in the gene drugs. I don't know why it's not. Scroll, oh, there we go. So if you're ever wondering if a medication has a guideline associated, these are organized by levels of evidence by CPIC, and then I'll show you what PharmGKB is, and then you can actually click here and see the guideline. So I'm just going to show you the guideline for tramadol and codeine and CYP2D6. So if you just click here, this one was updated, I think published in 2021. It gives a lot of nice background information and the literature reviews for you. It can get a lot into the medication metabolic function as well as clinical implications of the certain receptors. What I really look for here though, and there's that activity table I showed you, so you can go to see what, if you need to, if for some reason you just get the hard data. But what this does is gives you a nice summary. So in a patient, you have their phenotype. These are coding therapy recommendations based on CYP2D6. So like in our case example, we had a patient who was an ultra rapid metabolizer of CYP2D6. It's a strong recommendation to avoid coding because of the potential for serious toxicity versus an intermediate or poor metabolizer. It's a strong recommendation to avoid coding because of the lack of effectiveness and possible similar side effects. So when I show you some reports in a little bit, you're not going to be able to tell from that report in the green, yellow, red if the patient is more likely to be a non-responder or have adverse effects. And that also plays in. So it's really important to note that those reports have a lot of limitations, and you can further dive into, you might limit yourself to a certain therapy when in fact there's only a moderate recommendation to even do anything with the dose, if that makes sense. The other, hopefully this, tell me if this stops sharing, is PharmG KB. Don't mix those letters up. Not funny. This is an even bigger database. It gives you curated pathways. It houses any FDA labeling for annotations for medications. It includes the Dutch working group. So it's probably, CPIC guidelines are put into PharmGKB. So if you're ever wondering where to start, you could start here. Corey and I like this because it gives the metabolic pathways of medications, which is super neat. But as you see here, tramadol is converted by CYP2D6 to the active metabolite. Then it's either conjugated to an active metabolite. You don't really need to know this. I just think it's really neat. But here it will have any prescribing information. So here we see the CPIC guideline right there for the receptors and the CPIC guideline for CYP2D6. And if you pick the hyperlink, it'll take you right to the guideline and tell you how to dose the medication. This is if there's any FDA labeling, which there actually is for tramadol. So in patients who are ultra rapid metabolizers, the FDA labeling recommends avoiding tramadol due to the risk of adverse, life-threatening, or even fatal events. So the FDA labeling is also included in PharmGKB. So really comprehensive. There is on the homepage, you can kind of do like a walkthrough down here, and it'll show you what's all located in the website. So for those of you that had no idea, yes, there are guidelines and so much information out there for you. Let's see if I can go back to this. Right. Okay. Oh, you do? This is kind of annoying. And then the last part of the kind of knowing the what and the where, there are competencies. So there are several kind of certifications. There's physician competencies, there's genetic counselor competencies, there's pharmacist competencies. This Genomics Genetics Competency Center is actually a pretty cool website, which kind of gives physicians and providers and pharmacists kind of some other resources, upcoming classes, ways to stay up to date. since this is an ever-changing field. The place where all of the alleles are housed is PharmVar. So if you ever have something come up on a lab that you need to reference, that would be there. The Flockhart table out of Indiana is just a really good reference on all the different medications and how they're metabolized. So I think the more you learn about pharmacogenetics, the more you learn about drug interactions, which just makes you an overall better practitioner. But there are very useful references there as well. So is everyone asleep? How are we doing? That was like the biggest, quickest, broad overview of pharmacogenetics that I could give in this time. Does anyone have any questions right now? Okay, everyone's asleep, except for Dr. Dennis Sargreen.
Paul had a question.
Okay. So Shannon, I guess very useful information, but practically, so obviously, how do you test patients? I mean, are you advocating that we test everybody?
Good question.
And
Who do we test?
if so, how do we order the testing and how much does it cost and who pays for this?
Those are all great questions that I plan to answer right now for you. So there are definitely considerations for pharmacogenomic testing, and that is why I'm pretty avid before rolling out any of this testing that we do extensive education on it, because it can look really pretty and packaged in this pretty little report, but really what are we looking at? And so thank you for holding with me. I think retrospectively you'll look back and realize why I made you go through that first part of this lecture. These are the major classes that actually have guidelines that support clinical utility of pharmacogenetics. The biggest class and kind of management that we see is in the field of psychiatry. So here at Riverstone, we plan to roll this out in patients for psychiatric medication management. Now, that doesn't mean that if we test, so it's your genome, right? It's one and done. You don't need to retest. Sometimes new things come out and you retest, but not really. If we test for your psych meds, it might have implications for all sorts of other medications, right? So under the field of primary care, patients on psychiatric medications, chronic pain medications, and then overall polypharmacy, how are all these medicines interacting with their genetics? Do we need to streamline things? That's really where it comes into play. I'm not going to go into the heme-onc because that's its own field, really, of pharmacogenetics. We will have MTHFR polymorphism on our panel. And then clopidogrel will have implications as well. There are certain neurologic medications that require testing. Our testing does do the human leukocyte antigens for carbamazepine, phenytoin, Stevens-Johnson's reactions as well. And then what Dr. Gerbasi was saying, what about preemptive testing? So right now we're talking about reactive testing, where you're going to refer a patient because they've taken fluoxetine, duloxetine, venlafaxine, they didn't tolerate amitriptyline. We put them on quetiapine and Abilify, they didn't really respond. You're like, I don't know what to do. That would be a patient who would be a beneficial candidate for pharmacogenomic testing. So patients who have failed 2 or more medications in a class at a therapeutic dose for an appropriate amount of time, or they didn't tolerate it for an adequate trial. Those are the patients we're looking for. There are a lot of health systems that offer and are just doing preemptive testing, whereas we offer this, we test every patient that comes in, so we have the information ahead of time. So at the point of care, you get not only, okay, this patient, let's say me, because I'm a ultra rapid CYP2C19 metabolizer, you're trying to prescribe me a citalopram. Well, a drug gene alert pops up saying there's a level 1 recommendation that this patient will not respond to this medication. Selected alternatives include. So there are a lot of bigger facilities like Geisinger, I think Mayo might be doing it. That's also something implicated in pediatrics. How do we treat our pediatric behavioral health patients? First of all, we want to make sure that the evidence is a little bit lower in pediatrics, but if you get a test done and you're, a teenager, that could have implications at 50 when you have a heart attack. So how do we deal with that? So it's really important to know what you're ordering, to educate your patient on what you're ordering, and to at least know where the resources are to go to be able to utilize this, right? Because this is another tool in your toolbox. You don't have to do pharmacogenetic testing to prescribe any of these medicines, really. But there are guidelines on almost all these medications that I have listed up here. Every single medicine up here has a guideline for pharmacogenetics.
Shannon, when this testing gets done, it's the only testing, if I'm trying to do it for psychiatric reasons, that's the only check for the CYP, variants, or does the company uses the blood to check for other things, and how safe is that information as it may affect patients in the future?
Good question. So we're not testing for your future risk of the BRCA gene for breast cancer, other genetic issues. This is specifically the CYP enzymes and the receptors and some transporters and MTHFR. But it's not going to give you like your comprehensive map of your genome and what potential like Huntington's or some other genetic disease traits that you would have other genetic, like probably see a genetic counselor for. This is specifically for medication management and selection. Does that answer your question?
Yes, thank you.
Okay. I think I was talking to somebody earlier today about, NSAIDs. So a lot of our common medications we use for pain have pharmacogenetic implications. Tricyclic antidepressants is probably one of the most common medicines that we hear about patients not tolerating, right? Well, you see the two enzymes that metabolize tricyclics and the variants in our patient populations, not to mention that the medicine class itself already has high rates of adverse reactions. What the guidelines actually can do, though, is take their CYP2D6 and 2C19 phenotypes and tell you, okay, this patient, instead of starting amitriptyline 25, you should probably start at 10. Or you should avoid amitriptyline altogether and you should go right to nortriptyline, which is the active metabolite of amitriptyline. I'm not going to go into steroid metabolism or anything like that. And then again, we'll talk about these bigger classes in more detail. I don't know why I have that highlighted. Cardiology Pharmacogenetics is probably just something that Corey and I will identify when these panels are ordered. Clopidogrel being one of the most common, they actually have in some facilities point of care CYP2C9 testing where the patient's headed to the cath lab and they want to know what their CYP2C19 phenotype is to decide if we should load them with Plavix or use something else. Bigger tertiary centers are doing that at the point of care. It's like $189. But if we save a stent thrombosis and another PCI or a patient's life, is that cost worth it? I would say yes. Big implications for statin-induced myopathies. When in doubt, pravastatin, rosuvastatin, and that's really why, because pravastatin and rosuvastatin have lower metabolism by 3A4 and uptake by the statin enzyme. So that's why patients tend to tolerate them better. Here's just some other drug gene pairs that we won't even get into, but you can peruse the CPIC guidelines. This is the kind of, okay. This is the kind of, not the gold standard of pharmacogenetics, but something that just can give you some kind of clinical implementation or like thought process about how significantly this can impact patients. This was a newborn male who was normal weight, gestational age, born to a healthy mom. 7 days of age, he was having difficulty breastfeeding. He was somnolent, increased lethargy. 13 days of age, he ultimately was found down without a pulse on unsuccessful with CPR. Any other cause of death was ruled out in this patient. Toxicology reports showed his morphine serum concentration was 70 nanograms per milliliter. In a normal infant with receiving morphine, it would be 10 to 12 nanograms per milliliter. So he was 7 times the limit up there. What happened? Well, mom was prescribed Tylenol with codeine. Postpartum day 1 took 2 BID. Postpartum day 2 took 1 BID. She was also getting tired and constipated, so she stopped. Baby was not breastfeeding very well, so she froze her breast milk. Breast milk concentrations of morphine showed 87 micrograms per mil, with a normal breast milk concentration 2.2 nanograms per mil. So she had 40,000 times higher than expected codeine levels in her breast milk. This was explained by the mom and the baby's pharmacogenetics. So mom had 3 copies of a normal CYP2D6, so she was an ultra rapid metabolizer. Baby got 1 normal copy from mom, 1 from dad. He was a normal metabolizer. What happened? Mom converted codeine into morphine at significantly higher rates, accumulated in the baby, and he died of respiratory depression and morphine toxicity. And this is sad, but this is why codeine is contraindicated in breastfeeding. Dr. Gerbasi also asked about this. What are the challenges, utility, and limitations of all this testing in primary care? The coordination of the samples is a little bit of a process. It's getting better, but you can do a saliva or a blood sample. There are several different labs that you can go through. There's also direct to consumer testing. Your patients can get online, just like 23andMe, order their pharmacogenetics. They could walk into your office and say, I had this done, you're giving me venlafaxine, and this says that it's going to really harm me. And you'll be like, why did you do that? But you can at least walk them through it. But this testing used to take months. For DNA sequencing, be thousands and thousands of dollars. It's now about $200 to $300. We can get a turnaround time in 36 hours. Sometimes at the point of care, you're just doing single targeted ones. Insurances cover it. So the testing that we're going to be utilizing is GeneSight, and I'll show you a snippet of that and go into it in a little more detail in our next lecture. But Medicare and Medicaid, it is covered service. Private payers pay some of the cost, but usually a patient's max out of pocket is around $200. But you do have to send in all of the information with the sample to get a timely turnaround and ensure it's not lost. I don't know why I did that. So I kind of already talked about this. What I want to show you is that it's just not that simple. So this is the really pretty report you get from GeneSight. And it is nice, right? So these green ones look like, okay, dead venlafaxine, it's a go like every time. This patient might not do as well on trazodone. Well, does this yellow mean, what does it mean? Are they going to not tolerate them? Or are they going to have reduced response? Luckily, this one actually kind of gives you a little bit of information. Down here on the annotated right here. So serum levels may be too high, lower dose may be required. Serum level may be too low, low dose may be required. If you see your tricyclics over here, chances are they're going to be a poor CYP2D6 and have higher risk of side effects. But always at the end of the report, they'll give you their genotype and phenotype. So you can know, okay, well, amitriptyline's, sertraline's in the red. Sertraline shouldn't ever really be in the red. There isn't that good of data to support not using sertraline for the most part. So I would then address their genotype and phenotype and go to the guidelines to say, oh, all it's telling me is that you may not respond to this, but hey, I think this is a good choice. We'll just watch you more closely and we'll really get the dose to the appropriate dose it needs to be. Whereas doxepin, this is going to tell me absolutely avoid doxepin. This patient is going to have very significant side effects to this. we're getting better about, there's so much data out there and studies that you kind of just have to stay up with it. Regulatory and ethical concerns, again, could be its own lecture, but really what you need to do is educate your patients and be an educated provider. Don't order the testing without being able to describe it to the patient or let them know that just because this came back in the green, it's not going to be a miracle medication for you. So the FDA has a position on that as well. Really avoid direct-to-consumer testing. Our program here will have pharmacy involved for pre and post-test education for the patient and provider. And that's for patient safety and provider support, really, at how to appropriately utilize this. The ACE framework is something that is not just for pharmacogenetics, but any genetic testing. So when we're looking at the 4 pillars of genetic testing, we want analytic validity. So are the tests being run accurate, sensitive, and specific? Clinical validity, clinical utility, and then the ethical, legal and ethical. This is another place to go if you're wondering about other genetics, not just pharmacogenetics. Yeah, so we do a lot of education up front for providers and patients on ordering the testing, and then also post-test, looking at, you know, what medications would be beneficial for you. Patient-friendly language is something that's really important as well. Don't say metabolism. Patients, that's not that word means something different to a lot of people. You might process this medication a little faster or a little slower. And then always, if making a recommendation, we would be following up on that. I think we ran out of time. Does anyone have any questions or comments? Okay.
Great talk. Very
I was gonna say,
informative.
good job.
looking-
Thanks, Shannon.
Yeah.
All right, thank you.
Yeah.
Please log in 2 weeks because that's when we will actually get into the cases and more of the medication management piece.
And please complete the evaluation form for CME credit. Thanks. Thanks, Shannon.